Hello everyone, I am Dr. Rahul Mandlik from Medical Affairs at Shalina Healthcare, Dubai. Today I would like to welcome to this webinar where we are going to discuss one of the important health issue. I would like to extend our warm welcome to today's speaker, Professor Suchitra Pandit. Very briefly about our corporate profile, Shalina Healthcare is one of the largest pharmaceutical companies in Sub-Saharan Africa. And from last 35 years, we made it our mission of making quality healthcare products and to make them available at affordable prices across Africa. We manufacture these products at our own WHO approved facilities and we procure some of them from other WHO approved facilities. We partner with many government institutions, pharmacy boards, and NGOs to offer variety of healthcare services across Africa to our patients. And we conduct series of antenatal camps, malaria detection, or worm deworming camps. And we feel it is our duty to society to offer these programs and also to support our doctors, nurses, and pharmacists by providing them free education. So, in this endeavor, we are continuously conducting online as well as offline educational activities to engage and update our healthcare professionals in Africa. Well, today let me welcome our speaker, Professor Suchitra Pandit, who is going to talk about one of the burning women health issue, that is postpartum hemorrhage. Madam is going to shed light upon cost-effective and enhanced care program in the management of PPH. Well, before we start with the session, let me quickly take you through this rich experience of Madam. Professor Pandit is currently associated with Department of Obstetrics and Gynaecology at Surya Group of Hospitals, Mumbai, India. Dr. Pandit has worked for 3 years in UK. She has got MRCOG and FRCOG over there. And Dr. Pandit is former president of the Federation of Obstetrics and Gynecological Societies of India, that is FOXY, which is among us the largest medical professional body which has close to 40,000 members, gynecologist members. Dr. Pandit is president of organization Gestosis and ISOPAB, and Madam had chaired educational committee at one more reputed international gynecological association, that is SAFOG. Dr. Pandit has played a crucial role in drafting and designing guidance in the prevention and management of postpartum hemorrhage under Ministry of Health, Government of India. Dr. Pandit has worked for 8 guidelines along with Foxy, and she has published 115 publications in reputed journals, and she has authored 5 books. Dr. Pandit has been awarded with 30 orations and several prizes. Few of them are Madam is winner of FIGO Women's Award and also Lord of Planets Award from London. Dr. Pandit has been invited for over 2,000 guest lectures at national and international platforms. So while you attend this session, if you have any queries or if you like to provide any suggestions or feedbacks, please feel free to post them in the box provided, and we will take few of these questions during discussion session. So over to Dr. Pandit.
Thank you very much. And hello to all of you. I'm sure you'll have had lots of work in the different times, and now today you have kept some time aside for this educational webinar. I would like to thank Shalina Healthcare for having given me this opportunity, and to the DocMode for providing the digital platform. So, friends, today we will be talking about postpartum hemorrhage, which is one of the burning problems in the Southeast Asian countries. And I'm going to be discussing about how we can have a cost-effective and an enhanced care program. And I'm sure you'll have all recognized this very famous monument from India, the Taj Mahal. I don't know if many of you are aware about the background as to why it was built. It was in the memory of Mumtaz Mahal, who was the beloved wife of the Emperor Shah Jahan. And this was way back in the 16th century. She died during her 14th childbirth due to postpartum hemorrhage. And then Shah Jahan built this marble monument in her memory. The monument is beautiful, but we don't want monuments built in memory of somebody who's died due to PPH. We'd have rather have something built in memory of something gloriously done. The Universal Declaration of Human Rights, motherhood and childhood are entitled to special care and assistance. And what we have to now work towards is improving healthcare for women during childbirth to prevent and treat postpartum hemorrhage. And this is a very, very important step towards achievement of the Sustainable Development Goals number 5. So let's get on to postpartum hemorrhage. I'll be calling it PPH henceforth. So PPH is the leading cause of maternal mortality and accounts for nearly 25% of the global maternal deaths. And approximately 5% of women have PPH. When I say 5% in the women who are delivering. Majority of these deaths that occur do so within 4 hours of delivery, and majority are complications due to the third stage. So if you look at the prevalence incidence of PPH in the first pregnancy is 5.8%. Risk of a first PPH in second or third pregnancy is 4 to 5%, but risk of recurrent PPH once a woman has had PPH in the previous pregnancy, there's a risk in the subsequent pregnancy of nearly 15%. So now if we are talking about reduction of global mortality to less than 70 per 100,000 by 2030, PPH is the number one cause that has to be reduced to achieve this. Definition, I'm sure you're all familiar with this, but yet I'd like to reiterate the point that blood loss of over 500 ml from or into the genital tract or change of 10% in the hematocrit value following the birth of the baby is taken as PPH. But clinical definition says that any amount of blood loss that makes the patient hemodynamically unstable is termed as PPH. For cesarean section, blood loss of 1 liter or more is taken as PPH. Massive obstetric hemorrhage occurs when the estimated blood loss is more than 1500 ml. So PPH can be termed as minor or major. When you say minor, it means between 500 to 1000 ml. When you say major, major again is divided into two. Moderate, 1000 to 2000 ml, but severe is more than 2000 ml. So we have to make sure that if there is a PPH, it should be controlled when it is minor and not allow it to go into a massive obstetric hemorrhage. Primary PPH is more common and occurs within 24 hours of delivery, and the most commonest cause is uterine atony, whereas secondary PPH occurs between 24 hours and 6 weeks postpartum. Now, a rate of blood loss of 150 ml per minute or nearly 50% of the blood volume lost between 3 hours of delivery, or if the hematocrit falls down and there's a decrease in hemoglobin to 4 to 5, in these situations, again, we are looking at massive PPH. We've already defined that. So why exactly does PPH occur? So first, let's see what are the normal control mechanisms. Control of hemorrhage from the uterus after delivery occurs primarily by two mechanisms. First is vasoconstriction. Second is intravascular thrombosis. Vasoconstriction is provoked by the myometrial contraction, and this is the most important physiologic action. But intravascular thrombosis in the placental bed is induced by platelet adhesions, aggregation, and formation of fibrin. So have a look at this particular picture. When the woman is pregnant, there is an increase in vascularity and the blood circulation significantly increases. So, at term, a gravid uterus is perfused at the rate of 500 to 750 ml per minute. The increased blood flow to the uterus during pregnancy, therefore, increases the risk of PPH more so during a cesarean section. So, if you're looking at a C section, a normal, uncomplicated C section, the blood loss could be between 487 to 1000 ml. So, now let's come to the etiology and the risk factors. The most common and important cause of PPH is uterine atony. But remember, friends, 20% of PPH can occur in women with no risk factors at all. So, therefore, those of you who are involved in maternity must be prepared to manage this condition at any delivery. The uterus can simply pour blood and can lead to death within minutes if not immediately acted upon. If there is a hemodynamic instability, that is a problem. And in women who've got anemia, preeclampsia, or a low BMI, even a small blood loss, as much as 150 to 200 ml, can also cause a hemodynamic instability. So, main physiological causes of PPH, we call it the four T's. T for tone. 70% is because of uterine atony. This can be because of an over-distended uterus, chorioamnionitis. It could be iatrogenic. Trauma is 20%, where it's an episiotomy, lacerations, a uterine rupture, or extensions or lacerations at a cesarean section. Then the third T contributes to about 9%, retained products or abnormal placentation. It could be a succenturiate lobe or it could be morbid adhesions of the placenta. And thrombin, the last T, is 1% coagulation disorders or any kind of von Willebrands or ITP. So, which women in your antenatal clinic will you label as a high risk? Maternal causes and risk factors in labor. You have to take a detailed history and find out. So some of the important causes are maternal anemia. It's very important to make that woman's hemoglobin so strong so that when she reaches term, even if she loses 500 cc's of blood, she's not affected. And building hemoglobin by a nutritious diet, by deworming, by giving her the regular iron supplements is very, very essential. A nutritious diet where she's told about the importance of high protein and taking green leafy vegetables and different kinds of lentils and cereals. There are various iron preparations, and one has to find out what suits the women. But we must remember that the food taboos should also be told to her. Like immediately after meal, she should not take an iron tablet, she should not take it along with calcium, and she should take it at a time when the absorption is best because there are side effects like gastritis and constipation. But remember one thing that the newer salts have got a better absorptive capacity and therefore the compliance is better. One of the newer salts is sodium iron ferritate. It's available in the form of an iron syrup and every 5 ml provides about 11 milligrams of elemental iron. Then the other causes are grand multipara, women with a BMI more than 35 kg per meter square, previous history of PPH. Remember, this is a very important antenatal marker which you can put and you can label that woman as a high risk. If somebody is having an over distension of the uterus because of multiple pregnancy or large baby or polyhydramnios, again somebody who's got a low lying placenta or a history of high blood pressure, severe preeclampsia or pre-existing uterine anomalies, again these are high risk concerns. And let's look at the risk factors in labor. Initiation or augmentation of delivery by oxytocin, prolonged first, second, or third stage of labor, secondary arrest of labor, which can occur more commonly in multigravidas, precipitate labor, which leads to an atonic uterus, operative delivery or cesarean section, when you're using instruments like a forceps and there can be a huge financial tear, constriction ring, infection, and general anesthesia. So these are the important antenatal high risk concerns. And therefore, when you see your patient in the antenatal period in your ANC clinics, screen and treat anemia antenatally, as I've mentioned before. Screen for sickle cell disease and thalassemia, particularly in women of African, Southeast Asian, or Mediterranean descent. A lot of women, even in India, have thalassemia, and sickle cell is not so common, but we do screen for it at the first antenatal visit. Ultrasound is done for antenatal fetal surveillance, but you're also looking at the placental positions and more so in women who had previous history of cesarean section. Watch out for the invasive or the adherent placenta. Ensure that you have identified women who are Jehovah's Witness or others who do not want any blood products during delivery, and ensure that you deliver the high risk women, particularly in a facility where there is a blood bank and in house surgical services in case of PPH. And intrapartum management by protocol, use active management of third stage of labor, maintain a partogram. Very, very important, because then you know that your patient is not going to a prolonged first stage. And today we don't advocate a routine episiotomy, and you want to avoid traumatic instrumental deliveries and ensure that as soon as the patient has delivered, measure the cumulative blood loss and track the postpartum vital signs. But in situations where there is PPH, we must note the predictive values which I've already mentioned, preparedness, and then we should be able to handle. So, any woman who comes to you in labor, if she's a booked patient, you have notes to look for. But if she is an unbooked emergency, ascertain the hemoglobin level, the blood group, the RH type, and is there blood available? And at delivery, use the active management of third stage of labor. We call it AMSTEL. I'll be talking to you in a little more detail in the next few slides, but administer oxytocin within a minute of the baby's birth, control cord traction and fundal massage. So these are the strategies to prevent postpartum hemorrhage. And since I had to talk about what are we doing, I'm going to mention to you that you must have a team which has got well defined roles. For example, what are the protocols? Where are the drugs kept? What are the fluid records? How do you counsel the patient? How do you consent the patient? And what are the transport arrangements that you have, and what are the blood arrangements that you have? Establish a response team with well defined roles and readiness. The hemorrhage cart should be ready with all the medications which is required in cases of PPH or a postpartum collapse, the supplies, the checklist, the instruction cards, and there should be protocols for emergency as well as transfusions protocols. When there is time, the entire team must be educated on the protocols and run drills. In India, we do these PPH drills, eclampsia drills, very important to do them, and have a support program for patients, families, staff. And it's important to be able to appreciate any of your staff who've done a good job. And friends, remember, establish a culture of post event debriefs and auditing data. The components for active management of third stage we've already mentioned. It's a prophylactic, deliberate, effective intervention to ensure smooth expulsion of the placenta and for prevention of postpartum hemorrhage. And active management is a feasible, low cost measure. I'm sure most of you will be practicing, but nearly 60% of atonic PPH is prevented. And the uterotonic is the most important component. And let's look at this. So, administration of injection oxytocin 10 units intramuscular on the anterolateral aspect of the patient's thigh within 1 minute of the baby delivery. This is to help contract the uterus. This is a WHO guideline and we are also following it. Once the baby is delivered, a gentle uterine massage, and once you see the signs of placental separation, that is, lengthening of the cord, change in contour of the uterine shape, and fresh bleeding coming, start with the controlled cord traction and use delayed cord clamping because this gives additional amount of blood to the fetus. But if AMSTIL has not been followed, make sure that at least you've given the oxytocin in time. Diagnosis of PPH begins with recognition of excessive bleeding. And watch out particularly for the bed sheets, for the patient's feet, for blood trickling down. And therefore, there are some very important drapes which collect the blood and you can actually estimate the amount of blood loss. Monitor this throughout so that we have some kind of a quantitative measurement. So, friends, the golden hour has started. There is PPH. Handle now. Looking at the clock, we from Foxy talk of code H for PPH. Just as you have code blue for a cardiac arrest, you have code pink for a baby theft, we have code H for PPH. Shout for help and do these things almost simultaneously. Resuscitate, arrest the bleeding, communicate, identify the cause of the bleeding. And once more, we'll go through this. The critical steps, the 5 8s. We all love eating. So this is associated with 8. Communicate, all shout for help. Start resuscitation, A, B, C, D, and look at the hemorrhage. Start investigating simultaneously. Initiate the drug therapies, put on the IV lines, 2 IV lines, and if nothing works, then open up the patient, do a laparotomy, try your sutures, or harnessing the great arteries. So let's have a look. This is a typical clinical scenario in a labor ward. Shout for help, whoever is there in the labor ward. During anesthetist, during cesarean section, we are lucky we have an anesthetist with us. But most of the busy labor wards will have an anesthetist on call. Immediately press the emergency button, activate that emergency button so that the concerned people, the resident doctors, the nurses, the theater is all alerted. Quickly do a rapid initial assessment, A, B, C, D. Assessment of the blood loss, that is the hemorrhage, the breathing pattern, the circulation, check that it is all done, and start resuscitation. A very slow trickle is often more dangerous than a gush. Watch out for the pulse, the BP, and immediately simultaneously your nurse will put in 2 wide bore IV lines. The UK mentions number 14. In India, we are using 16 and 18. Withdraw 20 ml of blood for grouping and cross match, and another 10 ml for hemoglobin, PCV, coag profile, liver, and renal profile. And if possible, do an ABG, that is an arterial blood gas study. It is important to be able to start the fluids immediately because you have to collect the hypovolemia. Fluid replacement is important before the blood comes in. So start off with crystalloids, then to blood products. Most of the maternity units will not have fresh blood because the blood has to be tested, and by the time it's tested and all the important checks have been done, it is nearly 3 days. So you have blood components ready. And sometimes when you want to maintain the volume, you can use colloids. But by that time, your blood should have not been started. Remember, it is important to use crystalloids and not colloids. When you're using crystalloids, then you are trying to replenish the fluid volume. And if you take blood, if you give colloids instead of crystalloids, your blood grouping and cross matching may get faulty. So, therefore, use crystalloids first. Start off moist nasal oxygen at 4 to 6 liters per minute. Remember, friends, you need 10 hands, and therefore, you need 10 people to start doing these things simultaneously. Somebody has to start off the oxytocin. Massaging the uterus is more for prevention, but if actual BPH occurs, you have to ascertain the cause, evacuate the uterus. Sometimes there's a small piece of placenta remaining behind, and there could be a succenturiate lobe. But by that time, you have to alert the theater, catheterize the patient. I've just put this as a separate slide because 16 in India, we have 14 as the gray cannula. And in the UK, they use 14, we use 16 as the gray cannula, 18 as the green cannula, 20 as the pink, and 22. We never should use 20 and 22 in the labor wards. It should be 16 or 18. Now, in the meantime, you've started doing your bimanual compression. One can put a fist on the aortic region, so just to reduce the blood loss, and quickly start estimating the blood loss. Though it is a visual blood loss, we understand that it is less accurate, so you always add up a little more. Now, let's look through this great algorithm. Hemostasis. H, ask for help. A is assess the vital parameters. E is establish the etiology and ensure availability of blood. M is massaging the uterus. O is oxytocin infusion. Prostaglandins correctly intramuscular, intramyometrial. S again is the shock garment if you want to shift her to some other place. T is the tamponade. E is if you've opened up the patient, start doing the compression sutures, either B-Lynch or modified. S is the systematic pelvic devascularization. And if you are in a tertiary care center where you have access to interventional radiology, you could even take the patient there. And of course, if you feel in the course of events this is not possible and the patient still continues to bleed, think of a subtotal or a total hysterectomy. So, friends, the golden hour is the time in which resuscitation must begin to achieve maximum survival. Because as more and more time elapses between the point of severe shock and the start of resuscitation, the percentage of surviving patient decreases and there is a metabolic acidosis setting. Between 500 to 1000 blood loss, which is 10 to 15% of the blood volume, there may be a slight tachycardia, palpitations, and drowsiness. But as you're losing more and more blood, the patient starts sweating, has malaise, and by the time she's lost 1500 to 2000, she's extremely uneasy. The urine output starts falling, her BP drops down, and at 2000 to 3000 ml, she's lost 35 to 45% of blood volume. So she's in a severe shock, collapse state, has anuria, and the BP is just 40 to 60. So, friends, anesthetists always talk about the shock index. Shock index is the heart rate upon the systolic blood pressure. Normal heart or the normal shock index is between zero point 0.5 to zero point 0.7. But anything which is more than zero point 0.9 is taken as a state of shock and needs an urgent resuscitation. So, to follow the rule of 30, if there is more than 30% of the blood loss, if the heart rate is more than 30, the respiratory rate is more than 30, the systolic drops down to 30 or more, if the urinary output is less than 30, the hematocrit drop is more than 30, then the patient is already in a state of shock and begun if you have not yet started acting. And we don't want to reach the stage where there is a washout phenomena. The coagulation factors get completely consumed. And if this happens, there is a major, massive BPH. So let's have a quick look at the oxytocin. They must be started simultaneously as you are assessing the visual blood loss and starting on the IV lines, maximum of 60 units of oxytocin, methyl ergometrin. You could use a combination of oxytocin and methyl ergometrin. Of course, ergometrin should not be used if the placenta is still inside. And you can use carbopros, which is PGF2 alpha, maximum of 8 injections. Each injection is 2 milligrams. And if you feel that the bleeding is not controllable, you can start with the misoprostol. Also, it can be given sublingually, 200 to 400 micrograms. So initiate the drug therapy, do not delay. You've already done an active management of third stage. You've given 10 units intramuscularly. You infuse 20 units in 1 liter at the rate of 60 drops per minute, and don't give more than 3 liters in 24 hours. Hopefully, by that time, the BPH has got arrested. And giving an IV bolus can sometimes cause a sudden hypotension. In an active management, don't forget to do a controlled contraction. The combined effect of oxytocin and methyl ergometrin works very well. But ergometrin IV can act within 3 minutes. Intravascular takes about 7 minutes to act. So the advantages of oxytocin is it causes physiological uterine contractions which start at 2.5 minutes after an intramuscular injection. But ergometrin causes a sustained action or a tonic contraction. So remember, oxytocin causes the physiological contraction, it's a rhythmic action. And ergometrin causes a sustained action which can last for a longer period of time. There are contraindications to ergometrin like high blood pressure or severe chorioamnionitis or like an RH negative mother. But you have to use your discretion in this situation when you have to save the life of the mother. A combination of the two can be used. I wanted to show you this slide where you see that the prostaglandins are actually potentiating the action of oxytocin. So prostaglandins can be used as prophylaxis also in cesarean section, particularly high risk mothers where you feel she's already had PPH in the first pregnancy or she's had a low life placenta. You can give a prophylactic dose of 125 micrograms. The therapeutic dose is 250 micrograms and is given intramuscularly. PGF2 alpha has got side effects of nausea, vomiting, diarrhea. And in women who got a history of bronchial asthma, you don't want to give it unless you have an anesthetist with you who is ready to give a relaxant or something to take care of the lungs. In those situations, you can give it intramuscularly. But IM prostaglandins, a maximum of 8 injections can be given, and you can also give an intramyometrial prostaglandin. As I mentioned, prostaglandins increase the myometrial activity, the tone, shorten the third stage, and it is an effective oxytocin. Of course, WHO recommends oxytocin at the first line, but remember we also have that miracle drug, prostaglandin E1, misoprostol. For a prophylactic dose, what we normally do is post delivery, we give a 600 milligrams of misoprostol per rectally. There's almost immediate onset of action. During a cesarean section, we give 200 micrograms sublingually and then we put 400 per rectally. But in situations of PPH, you can even put 400 micrograms of misoprostol sublingually and you can give it later once the BPH is controlled, you can insert it per rectally. This big advantage is it can be stored at room temperature. With oxytocin and carboprost as well as methargin, that is ergometrin, we have to keep a cold chain. But for misoprostol, it does not require a cold chain. It has got an acceptable profile and it is very, very efficient. Even in women who have got asthma or a cardiac disease, misoprostol can be used. And WHO collaborative trial has said that maybe misoprostol is not as effective as 10 units of syntocinon. We still keep it as a second line drug. So misoprostol in third stage of labor, several papers, including a paper done at our own hospital, over 400 micrograms of misoprostol for a third stage prophylaxis done by one of my colleagues, Dr. Sanjay Rao, who's now working in UK. So friends, active management is great. We all should follow it because it reduces 60% of PPH. Oxytocin is safe. Misoprostol should be kept as a second line in your labor ward. PGF2 alpha is very, very effective as compared to methyl but it has its side effects of nausea, vomiting, and diarrhea. What about the second line of drugs? We must remember that if you're giving all these oxytocics, the muscles also require calcium. So adjuvant drug therapy and even your blood, when you're giving blood, you require to supplement calcium gluconate. So that can be given in an IV form. If the uterine atony is due to tocolytic therapy, again, this is of great value. You can also put in tranexamic acid. Usually we put in 1 gram of tranexamic acid in the IV pint. Ethiamylate 1 gram IV can also be used because they have a big role in stopping capillary bleeding. But in secondary PPH, the most common cause is infection, maybe a retained small little membrane, some kind of an infection. So in these situations, antibiotics, uterotonics, and evacuation of the cavity is very, very essential. So this is just a summary of all the drugs, and this is an important screenshot. Remember, all these drugs should be available at all given times in the labor ward. They should be supplemented. This is an important slide. In fact, Jabaigo has made a pictorial chart. This should be kept in the labor wards. Remember, if a patient has got PPH, which is limited, it is just fallen on the floor from the bed, that means her blood loss is more than 1000 ml. And if it is only on the bed, it is probably less than 1000. But if you see in front of you a kidney dish full of blood clots, that's about 500 ml. But if you have a 1 kg soaked swab, that's about 1000 ml. So these are different kinds of gauzes which have been found. Small ones about 60 ml, medium ones soaked about 140 ml. So these kinds we know. And if you find there's a 100 centimeter floor spill, that means 1500 ml. So these are again approximate estimates, and you can put this up on your labor theatre. So therefore, friends, one must be very familiar with the blood and the blood products. You must know about the massive transfusion protocol pack, that is the MTP pack. So 4 units of packed cells, that is PRBCs, 4 units of FFP, 4 units of platelets, and these must alternate with 4 units of packed cells, 4 units of FFP, and 8 units of cryoprecipitate. By that time, your platelet counts, the coagulation profile, the renal profile, and the liver profile, particularly the renal profile, the reports would have come. And if you find in the CBC the platelets are less than 50,000 or they are less than 100,000, in those situations, start giving a platelet transfusion. And if you find that the fibrinogen level is dropping down to less than 1 gram, which is the critical level, cryoprecipitate should be given. Therefore, in the coagulation profile, you are looking at the PT, APTT, and the fibrinogen, and use fresh frozen plasma. More so if your PT, APTT is prolonged. Use packed cells if the hemoglobin is less than 8 grams. And most of the times we like to give a supplement of calcium gluconate because we know that the levels of the calcium would have also dropped. So when you're looking at blood replacement, whole blood contains RBC, WBC, coagulation factors, and plasma proteins. And what does it do? It increases the blood volume and the hematocrit. But majority of the times, what we get in India in the maternity units are packed red cells, which are nearly 3 to 4 days old because they've gone through the entire tests. they contain more of red blood cells and less of WBCs. They improve the hematocrit, but there is a less febrile reaction with this particular because they don't have the plasma. So older packed red cells lack in the platelets, whereas platelet transfusions may be required, particularly if you're using an older packed cells, because they increase the platelet volume and they're particularly useful when a patient has got an ITP or a von Willebrand's disease. Cryoprecipitate is rich in factor 8 and fibrinogen, particularly useful when fibrinogen has to be increased. And then you also have the saline albumin, 5% and 25%. So the confidential inquiries into maternal deaths in UK and the ones done in India also revealed that why does a death occur because of PPH? Either too little of fluids or too little of oxytocin or too little of the blood clotting factors have been given, or they have been given too late. Prostaglandins were too late, resuscitation was too late, decision was surgery was too late, or getting a senior surgeon and anesthetists involved was too late. So in India, we have Kerala state, which has initiated this audit, and Gujarat, Maharashtra, where I stay, and Tamil Nadu have shown excellent reduction in mortality due to the NRHM initiatives. And today, India's mortality runs at 121 per 100,000, and we're hoping we go down to double figures very, very soon. So, friends, what happens if there is PPH which continues or which occurs as an emergency and the patient has been referred to you unresponsive uterine bleeding? You have tamponade techniques with balloons and gauzes. You have surgical methods, open up the patient, do a uterine massage, use compression sutures, different types, either horizontal full thickness, or you use figure of 8, or use sutures, or combination of various sutures, or you can resort to vessel ligation. You may not have time to do each and everything, but you have to quickly take your decisions and do what is best for the patient. And hysterectomy is a procedure which is life saving. I always call it the necessary evil. Sometimes you have to do it. And if you're in a tertiary care center where there are facilities for uterine artery embolization, by all means, effective methods for controlling intractable PPH. So let's have a quick look at the tamponade techniques, the gauzes, which are not very, very popular, the different kinds of balloons or the Sangstick tubes, the Bakri balloon. I'm going to talk to you about this. Now, why is this packing not very popular? Because it should ideally be done in a systematic manner. Tight uterine packing in a zigzag manner with a sponge holding forceps with a 16-meter sterile ribbon gauze soaked in hot saline. And the packing has to start from the fundus in layers from left to right. And it has to be so tightly packed, and the vagina also has to be packed to give additional pressure. But if it is not done correctly, you may be under a false impression. The gauzes may be getting completely soaked, and you may have a false sense of security. So it's not recommended very strongly, done only where nothing else is available. So balloon is definitely better than gauze because balloons are easy, available, simple, easy to insert, conforms well. The gauzes may miss spots and balloons do not absorb, so there's no delay, and they when you remove it, it doesn't cause bleeding. As when you remove a gauze, you're always worried about bleeding. So let's look at this balloon condom catheter, very simple, innovative technique. Remember, a condom can expand to 20 liters to stop bleeding, but we don't really need that much. All that we need is enough to fit into the uterine cavity. So let's have a look at this. One of our senior doctors who's retired now, Professor Shivkar, has devised this very simple technique. You can use a simple rubber catheter, a Foley's is much more better. Tie a condom, in fact, we use a double condom, and tie this to the particular tube. And once you've done that, you can connect this to a IV drip. This IV drip is then put on an IV stand, almost 60 centimeters above, and 300 cc's is then required to fill up the dead space of the condom and the uterus. So this is how it looks like. This is a model where the balloon has been inserted and it is connected to an IV stand which is 60 centimeters high, and this particular drip is running. The IV bottle is about 25 centimeters above the abdomen, tight vaginal packing because you don't want the condom to slip. You can also use a second condom there and temporarily give a firm external compression of the uterus. Your assistant can do that outer to inner side. This can be kept in situ for 6 to 8 hours. Once the PPH is arrested, you can have your simultaneous oxytocin going on. The pack can be removed by bringing the bottle down slowly by 5 centimeters every 15 minutes, so the uterus gradually contracts over the pack. And in cases of an early coagulation failure, you are simultaneously giving blood and blood products. Remember, this entire thing doesn't even cost half a dollar. When I talk of dollar, I'm talking of the US dollar. In India, this entire thing would cost just about 50 to 60 rupees. It's very, very cheap. This is how it looks like when it is blown to 100. Exactly look like it. We use a double condom so that we don't want that condom to tear inside the uterus. And nearly 101 cases were tried over 20 years, and 75 of them showed a complete cessation. 20 showed a partial response, which is nearly 95. 6 failed to show a response and they needed an active intervention. So, what is the mechanism? We understand that atonic PPH is caused because of the failure of the living ligatures, and we have to have them contracting to compress the vessels. So, the vessels are compressed, and this allows sufficient time for resuscitation of the patient. And the pressure goes up to nearly 21 to 48 millimeters. And then, once the pressure in the capillary system is lesser, the pressure of this balloon is higher and the pack stops the bleeding. There may be small little arterial spurters which are there, but generally they will completely stop. So atonic PPH, we know it's common, and the Shipper's pack helps in this particular thing. Of course, if you have access to an ultrasound, you can check out ultrasonologically whether there is any other concealed hemorrhage or whether there is a hematoma developing. And only if there is a suspected or uterine rupture, we don't use this particular Shipker's pack. And the advantage is it is dynamic, and once the uterus starts contracting, the pressure in the balloon increases and it pushes out the fluid, allowing the uterus to continue to contract. It is of a non-porous nature, does not absorb the blood. Infection risk is minimal, and the exact uterine pressure can be monitored. So problems of too light or too loose packing can be avoided. And of course, if you decide that you have to do a hysterectomy or an internal iliac ligation, you still will be able to minimize blood loss. Cheap and simple. So even a paramedical staff can be using it in low resource setting. Now, next we move on to the balloons. These balloons are slightly more expensive. We don't use the Sengstaker balloon, we use rushes very sparingly. But Bakri balloon is available in India, but it's expensive. It costs about 5,000 rupees, which is approximately $100. And let's see how it is. It looks exactly like this. It is designed specifically for obstetrical hemorrhage, and its capacity is 800, but you don't need to use more than 250 to 500. It's got a wide shaft and it can be used even in a cesarean section. The balloon can be put from inside and the shaft can be brought down from below. You to clean the cervix and vagina, determine the uterine volume approximately, and the entire balloon is inserted and then filled with 250 to 300 cc's of normal saline. No gas is used. And again, here you can put in a tight vaginal pack, and once the bleeding stops, you will get an idea. The patient will feel symptomatically better. Remember, these shafts are connected. There is a top balloon. I'm just going to show you this. This is the shaft which is connected to the cavity. So the bleeding comes out. So you know it is connected to the drainage port. So you know what is the hemostasis. So once the bleeding stops, this can be removed very gently by gently taking out. First, flush the balloon and the drainage port, and then you start deflating the balloon and gently take it out. So when you're doing this, count all the mops and the packs that you've used and gently retract the balloon, but monitor this patient because she may go into a vasovagal while insertion and even while removing, the BP can suddenly drop. So the advantage is this is easy, it is quick to ascertain effectiveness. We're able to gauge the ongoing blood loss, it is easily removed. So this is an important tamponade. But if there is a cervical bleeding or there is infection or if there is DIC, probably this device is of no use. And if the patient has got a ruptured uterus, again, you don't use a Bakri balloon. But it has got an important advantage. It can be used even in the smallest possible settings. It is expensive, but a local indigenous thing can be made and it does not require any anesthesia. The learning curve is very, very easy. So Bakri balloon is there. But the shift curves pack is much more cheaper and easy to make. This is, of course, this is just for your knowledge. This is a fancy ebb balloon manufactured in the UK. And this is the uterine pack. This is the vaginal pack. And it has got the internal port and there is an external port. It looks very, very fancy and is more expensive, but you should know about this. Remember, friends, patient has to be transferred to the OT for surgical methods or to the HDU or ICU for monitoring. So remember, if you're in a small hospital and you want to transfer, please arrange for an ambulance. India, we have this 108 ambulances which are available, very easy to do. You can shift the patient to this tertiary care center with these particular ambulances. So when you're shifting, think about the non-inflatable anti-shock garment. This is a pneumatic anti-shock garment which decreases the pelvic blood flow and hemorrhage, and a tightly fitting garment decreases the distal aortic blood flow and improves the survival rate. So temporarily it stops the bleeding so that when the patient arrives to the hospital, she's in a much more better shape. This is a non-inflatable anti-shock garment. This is devised from the masked suit which were there in the army. When the army people have a problem and they are bleeding, they are flown to the nearby center wearing the mask suit. So friends, if the PPH continues and now you've arrived at the tertiary care center or you decide to open her up by laparotomy, what do you do? If there is severe bleeding, you can put your fist or a mop on the aorta. Little few seconds, that bleeding can be quickly sucked out and you can decide meantime what to do. Ask for senior help and think of what to do. If you decide, you hold the uterus in your hand and start contracting and start massaging it. If it is contracting in your hands, these patients will improve with a B-Lynch or a modified B-Lynch suture, and you can decide what you want to do. Do you want to harness the arteries? Do you want to take a uterine and an ovarian artery, or do you want to go ahead with the internal iliac artery ligation? So these are the various conservative surgical methods. Quick decisions: B-Lynch, horizontal full thickness and vertical full thickness sutures, square sutures, combination of sutures. So Christopher Wheeler devised this particular thing, and the objective is to compress the uterus without occluding the uterine arteries. Simple technique to perform. I'll quickly show you. When you're doing a cesarean section, the lower segment is already open. But if it is in the context of a normal delivery and you've opened up the patient for PPH, you will probably have to take an incision in the lower segment. The suture material that is used is Vicryl, that is a PGA suture. You start from the lower segment, go through this, go over the uterus, go behind and take out your suture line from behind the uterus, come above, go through the upper segment and come out, and then pull it forward. After you've done that, close this particular lower segment, which you've already made an incision over there, and then suture up this brace. This holds it like a brace, but initially chromic catgut was used, but you can use a PGA suture also. So it can be done alone or in combination of other methods, and you can save the uterus. And if PPH continues, you have to decide what to do. My only problem with the B-Lynch, traditional B-Lynch, is in the context of a C-section, okay, the lower segment is already opened up. But in the context of a delivery and you opened up, you have to make that incision. A patient who's already bleeding, you're causing more of an iatrogenic problem. So what we prefer to do is the modified B-Lynch, which is modified by Richard Heyman and Professor Arul Kumaran. You can use a straight or a blunt needle to transfer the uterus, and I'm going to show you this video. Have a look at it. This is a teaching video. So in this particular case, what happens is you take a needle. You're hearing the background noise, so it's a real situation. You can hold the uterus tightly in your hands, and you can insert the needle from back to front, and then again from front to back. Remember, you have to take the needle half an inch medial to the angle. Your assistant holds the uterus very tight, and then you use the suture material. Initially, we had started using catgut, but when you make it tight, the catgut breaks off. Therefore, we use a PGA suture. And once you've tightened this up, you can just close it off. So this is what it looks like, and then you can repeat the suture on the other side. There are times when you can use a chromic catgut to just put a stay suture, and then you can actually feel the uterus contracting in your hands. Friends, you must remember that this is an easy technique to do and anybody can do it. Another thing what you have to remember is you don't need a vertical incision. You can do it in your transverse incision. So this is exactly what it looks like. Also remember that once you've done this, people are always worried, what happens to the vicryl or the PGA suture that you're using? Friends, this particular vicryl gets disintegrated within 25 to 90 days. So you're not to worry. This is exactly what it looks like, the suture at both the angles. And now we move to the next. So in cases of a broader uterus, more than one suture can be used. But remember, you will have to exteriorize the uterus and hold it tight and use very good pressure to compress the uterus when you're taking the sutures. We had this study at Sion Hospital, and we did it in nearly 40 cases of atonic PPH, and we were successful in 19 in about 25 cases. We did this conservative method. We use uterine packing in 2, we use interlinear ligation in 4, and in 19 cases we used the modified Balian suture, and these were successful in 17 cases, which is 90%. And the other 2 we had to go ahead and do an obstetric hysterectomy. So the advantage is it can arrest serious PPH. It's an invaluable alternative, and in many cases hysterectomy is avoided, so less mutilating, and follow-up reports suggest that there are normal return to menses. But points to consider with the modified is easy, no lower uterine incision is required, less time consuming, less hematometra, and less stenosis. Whereas in the traditional B-Lynch, you require to make that incision. It is time consuming and it takes a little more time because you're keeping the lower edges of the uterus open. So and because of the multiple bites in the uterus, there could be more of bleeding. So these studies have been done and you find a nearly 90% succession rate. So there are limitations. There has been partial necrosis reported, and there has been erosion of the uterine wall and a possibility of intestinal loop entrapment, but these are just isolated case reports. There are various other modifications. Instead of we've talked about these 2 sutures, you can also do a Cho stitch, which is square stitches. These work very well, particularly if you've got a placenta previa or an anterior placenta. You can use these square sutures, and the Cho sutures work very well, or you can even have the U-pin sutures, where instead of you're going all around, you can use anterior wall to posterior wall and back to anterior. You can use 2 to 3 U-pin sutures or square sutures. They work well. The principle is holding the uterus tight, they compress the anterior and the posterior walls. And there is also simple plication of the placental bed in cases of low-lying placenta. Now, this is some of the pictures, and this is again Gunashila's global stitch, where she's taken a purse string sutures all around the uterine wall. I've never done this, but I've used the modified B-Lynch and the Cho stitch. And the Gunashila's global stitch is supposed to again, but the principle remains the same. So, friends, when you're doing a cesarean section, try to minimize the blood loss. Avoid lacerations. If you have difficulty in delivery, extend your incisions in a J-shaped manner rather than transversely because it can go into the broad ligament plexus and cause problems. And these are the various strategies to minimize blood loss. Prefer spontaneous expulsion of the placenta and try to suture the uterine edges as soon as possible. In localized bleeding, you can use a mop. It might help uterine artery ligation and ovarian artery ligation. So let's look at the uterine artery ligation. This is the step one. You'll have to exteriorize the uterus and the UV peritoneum should be pushed right down so the bladder is out of the side. The step one is when the uterine artery is the uterus is held in the palm. This is the uterine artery and you when you exteriorize it you're sure that the ureters have moved off. The step two is just at the angle you decide you're going to take a stitch, hold the uterus, take a chromic catgut suture and pass the suture through the myometrium from the anterior and posterior. Do not skeletonize the uterine vessel and repeat the procedure on the other side. This works very well and you can see the change in the color of the uterus. But if you find that with the uterine artery ligation, you're not getting a result, you can go lower down and you can take a cervico-vaginal branch. And if you find step three, if you find that the bleeding is still there and the uterus is still very, very flabby, roxitosics are going on, you can do a bilateral ovarian artery ligation. And this is how it looks like. This is exactly where you take the stitch, where I mentioned to you, this is how it looks like in the real life. And there are minimal complications. Because you've pushed the bladder down, the chances of ureteric injury are minimal. But there could be a broad ligament hematoma, and therefore, don't worry. The stepwise devascularization also helps and avoids a hysterectomy, but this may fail in a placenta accreta or in a patient having a DIC, so probably doing a hysterectomy is a much more better choice. Now, what about internal iliac artery? It's a time tested, reliable procedure, difficult. You must be familiar with the divisions anterior division, posterior division, uterine, superior and inferior vesicle, middle rectal, obturator, internal pudendal, and inferior gluteal. But you must remember that you must avoid taking the posterior division. And remember that once you do an internal iliac artery ligation, you are not worried about having a problem to the rest of the pelvis because there is a collateral circulation, so gangrene does not occur. And you can do an intraperitoneal or an extraperitoneal. Most of the time, you're doing an intraperitoneal approach. On opening of the peritoneum, you identify the psoas muscle, the iliac vessel, and the ureter. There's a fibrofatty tissue which has to be dissected and gently retract the ureters medially. This is a Makester's artery forceps. Let it go under the uterine artery or the anterior division of the internal iliac after the posterior division has come out and use chromic catgut or you can even use a simple linen suture and take two ties 2 centimeters apart. Never ever divide because the knots, you're always worried about the knot slipping. So let's have this video. This was done by Professor Piley in one of the workshops approach. So the lower segment is opened up, you dissect the bladder slightly downwards, and as you're dissecting it downwards, you will be able to identify the ureter very nicely. Once you identify the ureter, you can gently retract the ureter laterally. The ureter runs over the vessels, and you want to be very careful. You do not want to, the ureter is running below, the vessels are running above. So you do not want to, when you're ligating, you do not want to take those ureter in the bite. So therefore, once you identify, this is the ureter, as you see very nicely. And once you see, this is a very beautiful magnification. This is the ureter. And once you've seen the ureter, you know that you have to completely. So this is the internal iliac and then the external iliac. So you have to identify anterior division of the internal iliac after the posterior vessels have gone away. So this is the internal iliac. Gently dissect the fibrofatty tissue. And then You take your Mixter's forceps. Remember, friends, there is a vein below that. You have to be very, very careful. So once you feed the, you can use a catgut or you can even use and then tie it up. So this is the way it is done. This is the anterior approach. There are other ways of approaching also. This is again another video, but let's move on. This is the posterior approach. Of course, this is done in the context of, and this is a video which this is a procedure which we are again more familiar with. You identify the division of the common iliac, the aorta dividing into the right common iliac and the left common iliac. Then the common iliac on the right side divides into external and internal. Once you have actually seen the external and the internal, if you have a look at this, you identify that very nicely. This is the internal iliac vessel, and this is this is the vein which is running right below, and the ureter has been gently pulled at the side. This is the ureter which has been gently retracted. Okay, and then you can start doing your. This is the anterior division. Go slightly below 2 centimeters below. You've already had the posterior division go away, and then you can hold the internal iliac, and then you can ligate it. Okay, so this is useful in selected cases. By doing a bilateral uterine artery and an internal iliac ligation, the mean arterial pressure drops by nearly 85%. Unilateral drops by nearly 77%. So you have to take a decision of quickly doing whatever you're doing. These cases are difficult. You have to have an expert with you when you're doing it. And if there's a lot of tissue edema, the visualization may be difficult. There may be a risk of thromboembolism. If you ligate the wrong vessel, you may end up having luteal region necrosis. There may be injury to ureter or vessels. So therefore, in situations, watch as many videos and do it on a model, learn your anatomy, and then do that. So this again saves up to nearly 80 to 85% of the uterine. I just want to show you this video. We are coming towards the last few videos. Artery, if in a stepwise devascularization, your uterine artery ligation or the lower step 2, that is a cervico-ischemic branches that you're doing, if that doesn't help, you can go on to the ovarian artery ligation. Herein, you are just identifying the uterine, the ovarian artery in the broad ligament, and then tying it up with a chromic catgut. And I wanted to show you this procedure also. Find there is a lot of flabbiness. Temporarily, you can make a hole in the broad ligament, pass a tourniquet through, and just hold the vessels. The uterine arteries will get compressed, and later on, you can tie the tourniquet. And once your work is done, you can actually remove the tourniquet, so the hemostasis is much more lesser. Remember, when you're doing this, these tourniquets are easy, and you can actually tie the tourniquets so that the bleeding is much more lesser. So this is just to show you how it is to be done. Now, newer strategies are the availability of recombinant factor. This is an expensive medicine and it costs quite a bit, but it is available in some of the tertiary care hospitals. And you have to have a hematologist say that, yes, go ahead and give the recombinant factor 7. Useful if there is a DIC. It's a man-made activated protein that promotes thrombosis, and the adult dose is 40 to 90 micrograms per kg. There are contraindications to it, documented hypersensitivity. This is what it looks like, recombinant factor 7. It works as a tissue factor via the extrinsic pathway and binds to platelets and activates the factor 10. So this is Novo 7, not available everywhere. And then if you have access to the uterine artery embolization, of course, this is not there in all the smaller centers and the resource poor settings, but you must know about this. Uterine artery embolization is indicated in severe cases of PPH. If all the primary measures fail, this can be considered as a life-saving option. And here, medium vinyl size polyvinyl particles are injected. via the coaxial catheters into the uterine arteries, and selective uterine artery embolization is safe and effective. Works very well if you have secondary PPH, if the patient is come to you and you're in a center where these facilities are available. Or when we know, I was working at Kokila Bain Hospital, which is a tertiary care center. We used to get cases of morbid adhesions of placenta accreta referred to us. So antenatally, when we identified them, we would, when we decide that we have to do a cesarean section in 37 weeks, we would take these patients down to theatre, of course, after counseling. With the help of the CM, the interventional radiologist would put in the femoral catheters and would, when we are doing, and then shift the patients to the theater, we take a vertical incision and we, if the percreta or the accreta is posterior, we take a vertical classical cesarean incision, take the baby out, leave the placenta in situ, and we proceeded to a hysterectomy. At that time, the interventional radiologist would give like a tamponade effect, so the bleeding was minimal. So once the hysterectomy was over, they would remove the tamponade. If there are places where they have retained the uterus, they have injected the polyvinyl particles into the uterine vessels, and they've left the uterus along with the placenta. The patient is observed for the next 48 hours in the ICU, and after 7 days, you actually start finding that the uterus is involuting because the placenta inside is starting to get necrosed. Methotrexate is given, and the uterus is actually retained. Of course, these are the conservative approach is done in centers where there's a possibility of the patient coming back. But I have experience of doing a hysterectomy, particularly where we had all the cases that we had placenta accreta or percreta going into the bladder. Of course, these are the review of literature shows that it is safe. There are side effects. There have been instances where the patients have actually got pregnant after this procedure whenever they want to. However, we are a little skeptical. These are newer things that are there, but you must know about it. And it is again life saving. In secondary PPH, we found that it works really very well, and we've managed to avoid doing a laparotomy or doing a hysterectomy. But friends, what you must remember that if uterine artery embolization is not available, don't worry. You have your conservative and your other surgical methods. If nothing works, take your decisions in time and do an obstetric hysterectomy. It is the necessary evil to save the life of a woman. In a bleeding placenta, accreta, percreta, rupture uteri, and if you feel there's an inadequate response to blood or hemodynamically unstable patient, traumatic PPH, go ahead and do an obstetric hysterectomy. It could be subtotal or it could be total. Of course, when you're doing it, remember it should be the last option, but quick decision. But if you're doing a subtotal, ensure that there is a stump hemostasis. There's an increased morbidity. So keep drains, make sure that blood is available. Observe this patient in ICUs. Remember, the patient needs a lot of counseling once she's come out of the surgery because she's lost her uterus, she's infertile. If this is a second pregnancy and if she's got one or two kids at home, she's happy. But if this is a first pregnancy, she's going to be very, very unhappy. There's a lot of psychological trauma. Subtotal hysterectomy sometimes is quicker if you feel the patient is in, she's got severe hypertension. You can do a subtotal hysterectomy much more easier. And in situations of placenta accreta, it probably may not help, but in an atonic PPH, sometimes a subtotal may help. But ensure that you have stump hemostasis. Friends, you give blood to the patient, but you still may need to give something more than that. Post-operatively, you can think of intravenous ferric carboxymaltose, and a large dose can be given post-surgery so that the hemoglobin is replenished. And once the patient comes back to normal and she still has low hemoglobin, think of oral iron. You can give oral iron supplements in the form of tablets or oral liquids, many, many molecules available. Choose the one that suits the patient. The newer molecules like sodium ferritate do help in reducing the side effects. But friends, this very, very important algorithm. If you want to save your mother from BPH, do not forget the critical steps. Communicate, resuscitate, investigate, initiate, ligate, and take your decisions very fast. And therefore, the drills and the response team is very, very important. These are the algorithms which you must put up in your labor wards. I'll quickly run through this. These are the last two slides. Resuscitate, check the placenta. Is the placenta retained? Please remove it by Brand Andrews technique. If it is not separated and if you feel the patient is still losing blood, shift her to theater, catheterize her, arrange blood, do an MRP. And if you feel that the placenta is not coming out and there is nothing else you can do, if you have facilities of UAE, fine. Otherwise, you may need to proceed to a hysterectomy. So, the general PPH algorithm, all the resuscitative measures, if it's a flabby uterus, uterotonics, uterine massage, bimanual compression, packing, and you feel it's still not working, tamponade with the balloons, shift the patient to the theater, open up the patient, do a B-Lynch suture or a modified B-Lynch, harnessing the great arteries, or consider hysterectomy. But if you feel that the uterus is well retracted, it could be traumatic. Suture, it could be a bleeding episiotomy or a deep financial tear which requires to be sutured in the theater. And if she's still bleeding and you've got your coagulation profile ready, give her blood and blood products. And here again, uterine artery embolization may be of value. So, friends, the most important decision is when to reinforce medical management with surgical management to save the life of the mother. And experience counts, skill counts. Therefore, when you're training the junior doctors and the nursing staff, please enforce the protocols which I mentioned. Ensure that there are checklists, protocols, drills, and audit data, and ensure that all the important drugs are always available. Thank you very much for a patient hearing.
Thank you so much, ma'am, for bringing these very grounded and practical tips. And thanks again for presenting such a rich and relevant repository of medical images as well as surgical videos. I'm sure it is going to be very helpful for our doctors and our healthcare professionals based in Africa. While we are moving now to discussion session, and I'm just
Yeah.
going through the questions. There are many questions which you have already addressed during your session, and
Yes.
but there are still few questions which I would like to put here, ma'am, and request you to respond to them.
Sure.
Uh, as we all know that, ma'am, PPH is one of the leading cause for maternal mortality even in sub-Saharan Africa today.
Yes.
And
Yes.
and there are many causes, like there might be delay in reaching to the hospital, or there might be delay in making available emergency obstetric care, or maybe
Right.
there are even deaths during transfer from one hospital to another hospital, right?
Yes.
So there is one question that how one can take care of PPH out of hospital setting.
Right. See, what's very important is that is why your first, let's go back to your registration. When the patient comes to see you in your antenatal clinic, remember in the slides I had mentioned about the high risk factors, identify them, build up the hemoglobin of the patient, identify the high risk factors, mark, put a pink card or put a red mark that this patient is likely to go into PPH. If the patient has had a previous PPH or she's had a previous history, or if this time she's got twins or an over distended uterus, all those are the high risk factors. So be prepared. So if you are in a setup where nobody else is there, first thing that you do is ask for help. You must have one more person with you. Immediately start off the IV line, take blood for cross matching and for the investigations. Put your hand inside the uterus, do a good bimanual massage. If you feel that there are some clots because of the placental bits remaining, remove off everything and tell your nurse to start off an IV with oxytocin, 20 units of oxytocin in 500 ml. And if it is possible, tell her to immediately call another person or an anesthetist. Why? Because if there is a placenta inside and you have to remove it or a placental bit, you may be able to remove it. But if you have a little bit of anesthesia, it may help. To evacuate the uterus and do a good, this is the thing, you do a good bimanual massage, and many a times the uterus starts contracting. Pat the uterus has done a big job during labor, so pat it and try to get it to contract. Start off your oxytocin, run the 20 units. If you feel the uterus is still flabby, give her an intramuscular methargin, that is a methyl argometrin, and give her injection carboprost if you feel, that is the PGF2 alpha. If you feel that this patient is still bleeding, and of course you must be sure that she doesn't have any cardiac problem. But if you feel there is a cardiac problem and you don't have PGF2 alpha, misoprostol, wonder drug, keep it with you. 200 micrograms can be quickly put under the sublingual region, and you'll see that the uterus starts contracting. In Malaysia, they had a very nice project where the women still delivered at home. So in a small village in Malaysia, what the government did was all the midwives, they gave them a packet of misoprostol, and they told them that as soon as the woman is in labor, you keep that packet with you, and as soon as the placenta comes out, you just keep 200 micrograms of misoprostol under her tongue. Placenta comes out and the bleeding will be stopped. It was given like a prophylactic. So these are the simple things that you can do. But if you feel that this patient is continuing to bleed, this balloon catheter, which I told you, very easy. Shivkar's pack costs less than a half a dollar. Just take 2 condoms, tie that Foley's catheter tight, attach it to an IV line, put that balloon inside the uterus and at least 25 centimeters height of the IV drip, and quickly run in saline. As the balloon expands, it goes to, you can go up to almost 300 to 400 cc's, and at the same time your hand is in the anterior fornix, gently massage the uterus. Your oxytocics are going on, you'll start feeling the uterus is contracting. And meanwhile, pack up the vagina nicely. So that also gives an additional pressure. So these are the simple things which you can do. We can save our mothers. And if that hemoglobin is very good, say she's got a hemoglobin of 13 or 14, even if she loses 1 liter, she's still in a good position. But if she's got a hemoglobin of 7 or 8, she loses even 100 ml, it is dangerous for her.
Okay. And ma'am, since PPH is quite serious issue and which requires professional and experts intervention, maybe paramedics and doctors. But as you have very nicely mentioned one example from Malaysia, that how Malaysian government or this program was run, and they provided misoprostol 200 microgram at homes. So even though it is quite serious issue, ma'am, but is there anything which one can consider, as a part of first aid and the care to be taken at home?
See, I think when a patient is at home, what we recommend now, the Indian government has done a wonderful job. They have recommended that all women should deliver in a hospital, whichever hospital. There are government hospitals which provide, actually give money to the woman to deliver in the hospital. It is called as Janani Suraksha Yojana, which means save the mother, and the local midwives, we call them the ASHA workers, they motivate the patient right from the third month. Please put your name in the hospital, register yourself in the hospital. So these women are motivated to deliver in the hospital. The advantage of delivering in hospital is at least you have access to IV line, you have access to midwife, you have access to a doctor, and you have advice to certain drugs. And whatever the high risk women are, they identify them, and seventh month itself they transfer them to the bigger hospitals. I want to mention here that Sri Lanka has come up with a very beautiful program. They have maternity units which cater to difficult cases, like say a woman has got placenta previa. In the seventh month itself, she is transferred to a house which is near the maternity unit, so that if there is any bleeding, she just quickly in 5 minutes to 10 minutes she can be transferred to the hospital, and she is kept there. It's a house like a hospital house where the patient is looked after till she delivers, so the transport problem then is not there. So I think smaller places like in India also, now the Indian government has done a brilliant role, and now almost 98% of our women are delivering in the hospital. The only exceptions are the tribal women. So I think you in your country also can start doing that, encourage women to build up the hemoglobin, have a good diet, to limit the family size to two or three maximum, and to ensure that the interval between two births is at least a minimum of 2.5 to 3 years, and to register in hospital for delivery. Deworming, as Dr. Pandit had mentioned, that they're running the deworming program even in pregnancy. After the 4th month, we can routinely deworm the women, because if there is bookworm infestation or a roundworm infestation, they tend to lose hemoglobin. But building up hemoglobin is very important.
Perfect. And ma'am, you have mentioned about the guidelines, like there are many guidelines internationally available and even from
Yes,
WHO. So,
yes,
but now the implementation of guideline is very challenging, particularly in resource poor settings. So,
yes.
we would like to know from your own experience of implementing these PPH management guidelines in India.
Right. See, that's a very, very important thing. About 10 years ago, we had this difficulty. The guidelines would be made, government would make something different, FOXCR, Federation would make something different, medical colleges would find something different. So, what we have done now through FOXY, we have tied up with the government, and the government actually invites us as experts. So, we are involved in making those guidelines. They are there on the website, and I was involved with the PPH guideline with the government, and those guidelines are available on the website. Then we train, we have got three levels of training. We train the doctors. There are lots of volunteers, even from the private practitioners, who volunteer to be trained. We have the government doctors who are trained. So that is the first level of master trainers. Then the master trainers go and then train in the medical colleges in smaller setups. And Foxy has got around 40,000 members, and we have nearly 250 societies. So every society has a group of 200, 300 doctors. So what happens is these master trainers move into the various societies. So the level 3 training goes on. And the midwives through the EMOC program, there's the emergency obstetric care, they are again trained. So the level of training goes on, and then we have conferences, workshops, teaching webinars where we show videos, where we keep talking about the protocols. So this is the way we have trained, and we have managed to get down the mortality due to PPH to a significant amount. I think youngsters, the younger people also need to be trained, because they are the incoming people. And our future rests with the younger people. So training them is extremely important.
Right. And ma'am, regarding anemia, you have mentioned that anemia is one of the risk factor. During active management of such cases, transfusion or injectable irons are required indeed. But what is your opinion, ma'am, about switching such patients from injectable iron maybe after discharge from hospital to oral hematinics, and how long it can be continued, oral
Yes.
hematinics?
Only if you give injectable, then for 1 month you need not give any oral iron, because the receptors have all got saturated. But you must call this woman back after 10 days, see how she is feeling, and then call her back after 1 month, because she must start off with hematinics after 1 month. You can do a hemoglobin check, find out what her levels are. If they're above 12, great. But if she's still on the lesser side, because remember, woman also has to feed her child, she has to look after the household also, just to get back to a regular course. So in that situation, we advise her a high protein diet, and we ask her to start taking oral iron. But if you've given injectable iron, we start after 1 month. But if you've not given injectable iron and you've given blood only, then we can ask the women to start on discharge itself, start taking the iron tablets.
Okay. Ma'am, I can see one question from Dr. William who would like to know whether can someone combine oxytocin and misoprostol in the management of PPH cases?
Yes, absolutely. In fact, it's in a graded fashion. For the routine cases, you're using oxytocin as per the WHO protocol. But if you find that the patient has started bleeding, your oxytocin is going on. You started running it at a faster rate. Of course, you can put in misoprostol sublingually. You can use 200 to 400 micrograms sublingually. Rectally, if the patient is bleeding, it's not going to have much value. That's why we put it sublingually. And you can also combine it with methyl argometrin intramuscular. So give methyl argometrin, and if you feel this is still not responding, give PGF2 alpha intramuscular. 250 micrograms of PGF2 alpha intramuscular. If you're doing a laparotomy, you can even give it intramyometrically. Mind you, can give it eight injections of carboprost uh, with a gap of 10 minutes. But generally, you don't need to use so much of, because by that time, the uterus should have started contracting. And with your conservative methods, if it's not contracting, just consider a laparotomy and do your conservative surgical methods, which I mentioned.
Okay, and ma'am, in case if uterotonics are not working and they have failed, and if need occurs for tranexamic acid, and if 1 gram of tranexamic acid is injected and still bleeding is not controlled, in that case, can someone repeat the tranexamic acid? If is, after how long?
Okay, I'll tell you what we have now started doing again as per the NICE guidelines. If we are doing a cesarean section, we put 1 gram of tranexamic acid in the IV pint itself. And in the context of a normal delivery, if you find that the patient started bleeding, we put 500 grams in the pint. I won't say it is a drug which will work if the primary uterotonic fails. I feel it should be simultaneously used. If the primary uterotonics have not failed properly, because it's so atonic that you can try your ethamsulate and your tranexamic acid, but by then your decision to move the patient to the theater and open up dual laparotomy is important, because it's not as though one may work or one may not work. You can try almost simultaneously. You don't have to wait and say, okay, now I'll wait for this to act. Now you have to do it almost simultaneously.
Right. So I think I will go for the last question now. Ma'am, there are many kind of hospitals, right? I mean, there are primary care setups and even very small district level hospitals, which might not be having the facilities as good as tertiary care hospitals, as far as infra as well as the skilled staff. So for
Yes.
such centers, which are the 4 5 very crucial things or items which you would recommend to be available in such setups?
Okay. First and most important thing is your staffing is very important. They should be motivated and train them. So training and drills are very important. The infrastructure must have a proper delivery table, must have a good light, must have a cart, a drug cart, where you've got all the essential drugs kept there. And oxytocin, methargin, carboprost all require a cold chain, means they require to be refrigerated. Misoprostol is the only drug which does not require refrigeration, can be kept in the open. IV fluids important. Keep at least ringer lactate, normal saline, and you these are crystalloids, and you also keep colloids. And so the drugs are important, the IV fluids are important, cannula. A number 16 or 18 cannula, adequate number of cannula should be there. Foley's catheter, because you need to catheterize the patient. If you want to use it as a tourniquet, Foley's catheter can be used for multiple amount of things. More so, condoms should be kept, and train your staff to make a condom catheter. What we used to do is train them, and they would take the condom, and two of them tied to the Foley's catheter, and fill in water and see how much it expands to, and it stays for a long time. This would be important. Oxygen, central oxygen is also very, very important. And I would say if it's a very small center, keep a mask suit. That is, as I mentioned, the suit which, if you want to transfer the patient, it tremendously helps in reducing the blood loss and keeping the patient's brain proper good supply. You remember, when there is an acute blood loss, there is blood which moves away from the other organs and goes to the brain. But if that also starts going, the patient will start getting acidotic. So to prevent that, keep a mask suit. They're very cheap. Those rubber suits, they are made of polyvinyl material. They're available, easy to tie. So keep those mask suits, and keep one central board where you have your protocol for PPH, your drug protocol, the dates of the drug expiry, and the numbers, important number for the anesthetist, for the doctor, for the assistants, and a functioning phone where you can call your ambulance, and an ambulance which works. I would say these are the basics.
Thank you so much, ma'am, for such a wonderful and very remarkable presentation. I would like to thank our all audience, doctors, nurses, and pharmacists, all from different countries in Africa, for taking out time from your busy schedule to attend this webinar. And
I hope
lastly,
they have all liked it.
yes, ma'am, certainly. We are also hoping for that, and we'll share you the feedbacks from our attendees. And lastly, I would like to thank Nigeria Medical Association as well as PPB Kenya for accrediting this webinar and issuing CPD points to our attendee. So all doctors, nurses, and pharmacists, please stay tuned to our post, which we keep on sending through WhatsApp or email, or we keep on posting on our social media platforms, so that you will be updated and you will know that when is our next webinar coming up. Thank you so much.
Thank you very much and have a good day and save all the mothers from BPH.